Thank you very much for everybody that has checked in. I've been looking forward to doing this program for a long time. And when we look at the title, Everyday Comprehensive Aesthetic Dentistry, I think everything that we do all day in our general dental practices, I'm a general dentist, I think it is aesthetic. And I think in the next tagline that this is the key to our practice growth in the coming decade. And so I hope today what I'm able to do is show you some different ideas, some possibilities. And when you think of these possibilities, when you go back to work tomorrow, that it actually enhances your practice. So we're going to let's see, let me just get this off. Let me get that. There you go. First, I'd like to just say thank you to Catapult Education for allowing me to present and thank Dr. Lou Graham. Lou and I have been friends for decades, and I will tell you, I really respect Dr. Graham because he has always tried to enhance our lives as dental colleagues by bringing us education and now other special business services that will help us survive in the future. So if you haven't checked those out, I encourage you to do that. But I just want to thank Catapult and Dr. Graham for allowing me to present. Let's look at this case. This case is just something that might come into your practice at any time, any day. Patient comes in and you can see the front six teeth, cuspid to cuspid, are a little discolored. She has really white restorations on the bicuspids, and then a little dark margin over there on the upper left first bi. And I think this is just a typical case we might see where a patient comes in and says, you know what, she wants an aesthetic enhancement of these teeth. How do we handle that? I think somebody who has teeth that don't look really, really bad, it takes a little bit of time for us to develop our plan. So we're going to talk about that. How do we develop the plan so we understand what the patient wants? And then how do we create restorations that meet their vision? So I think aesthetics has to be addressed in our practice. It doesn't matter if we're doing implants or if we're doing dentures, if we're doing a full mouth rehabilitation or a single mesial and incisal composite on a upper right central. Um, I think that's important because patients don't come in saying, I need to have my teeth fixed and I want ugly teeth when we're done. Everybody wants teeth that look nicer than what they come in with. And when I look at the possibilities of this case that we started off with, again, I'm going to try to figure out one, what are the patient's desires? Do they want to change the color? Do they want to change the shape? There's a little bit of wear on the teeth. Do they want to make the teeth longer? And if we do make the teeth longer, how is that going to affect the function? And if we jump way over to the right-hand column, I'm thinking about the material that I want to use to get the aesthetics and how that the patient desires and to get the strength that I actually want to have so that we have longevity in our restorations. So these are some of the questions that I'm thinking about as I'm talking to my patient and thinking about this. So on the right-hand side, our patient's left-hand side, these are the restorations that we placed. And on the patient's right-hand side, or what we see as the left-hand side on this slide, that's the central lateral and cuspid that the patient presented with. So when I first started the conversation with her, I said, well, there's a lot of wear and tear on these teeth. So do we want to take care of that functional issue? And then how do you want the teeth to look? Because you've got these bicuspids that are super white. Do you want these front seven teeth to be as white as that? Well, I said the front six, so I was looking cuspid to cuspid. And she said, no, I don't want it to be that white. I want them to have a natural appearance. And she wanted even some incisal translucency. And it's funny these days when we talk to our patients, we can use terms that we couldn't use just even 5, 10 years ago because they didn't understand the dental lingo of terminology. And today, with Dr. Google out there, they're studying and they come in, they're asking us questions and using terminology that makes them sound like a dentist. But she wanted some incisal translucency. She didn't want a chiclet look. She wanted a little bit of surface texture. And that's what we see on her left-hand side, our right-hand side of the slide. So one of the things I want to have you think about today is if I went into this case and I sat down to figure out what the patient wanted, and I had a pretty good idea what I needed to deliver, but I didn't have the laboratory to make the restorations for me that matched that vision, I would be under a lot of stress. So what I want to emphasize to you is that if you can find a laboratory who's on the same wavelength, they understand smile design. And what I do is I send photos maybe to a lab. I could send models and request their input even before we get into doing the case. That just takes all that stress out. Because the patients don't see our preps, not like dental school where we would get judged on, good preps or bad preps. All they see is the final aesthetic result. And that is why it's so important to have a good lab. The patient's not going to say, I love your preps, do that for me. They're going to say, I love that smile. I want you to create that smile in my mouth. It's that final aesthetic, that the restorative work that they really focus on. So one of the things I'm going to go through a lot today is find a lab that has your vision, that understands what it is that we need to do to deliver that smile. In this patient's case, what we did is we took some pre-op models, had a diagnostic wax-up done. With that diagnostic wax-up, we had a temporization stent fabricated, putty stent. And after we prepared the teeth, we were able to make the temporaries that kind of previewed what the final restorations would look like. 3 weeks later, these are the temporaries, her tissue. She took a really good care of the tissue, which made the cementation or delivery of the restorations much easier. Now, one of the things that we have to worry about, and I thought about this oftentimes, is, well, how about all the adjustments? If I do multiple units, am I going to have a lot of adjustments I have to make when I go to cement the case in? And again, you want to have a lab you can depend on, a lab that you don't have to worry about having to make a lot of adjustments. So the lab that I use, the Pacific Aesthetic Continuums lab, they put the restorations on the solid model. So it's not the Pindex model where the dies can move back and forth mesial distally. This is a solid model, and these are full coverage. The patient wanted full coverage, and she had a lot of lingual wear, so that's what we decided was okay to do. We'd have very conservative preps on the lingual. But what is priceless to me as far as my lab work is, one, that I get it on time. If I schedule a patient back in 2 or 3 weeks on a Monday at 8 o'clock, I don't want that case to show up Tuesday at 2 o'clock. I need to have it there before. So pick a lab that will get that case to you on time and that they're dependable. Make sure that you have a lab where you don't have to worry about the fit, that they put the time in to make sure that the restorations will require no adjustment or very little, if any, when you go to cement that case. Make sure you use a lab that can deliver the aesthetics and the contours of the restorations that you desire and the patient is seeking. And again, try to make sure that they can fine tune that case so there's minimal need to adjust contacts and the occlusion. So this is the way her case turned out. And I think the lab did a great job. They have very nice color in these restorations, a little bit of warmth at the gingiva, the incisal translucency, and just really nice surface texture to make this case look very natural. Even though the restorations are lighter, they don't look like chiclets. And if you look at the response of the tissue, again, the marginal fit was so nice that the case went in, and this was a couple of years ago. And every time I see her, she mentions how she loves to smile. So this is the way that I look at this is, to me, this is dental, I know, artistry. Um, it's the word, and I want you to understand that the dental artistry is not a commodity, that we have to value it. The word commodity means a basic good that is interchangeable because it is essentially uniform in quality across producers. And how many times do we get on our phones, we look at for something on Amazon and we look for the ratings and we look at the price, right? If I can get the same product at a lesser price, then that's probably what I'm going to order. And so today we consider so many things a commodity that we shop for that best price. But to me, art's not a commodity. As the quality of the art differs from producer to producer, and to me, dentistry still allows us to deliver something that's artistic. It's a crafted product that the laboratory and I work to bring to the patient. It's one that we practice and we try to improve on with every patient that we treat. And what I want dentists to understand is we shouldn't be shopping around for the least expensive lab work, but the lab work that we can take pride in, that when we deliver the restorations, we feel good about delivering that type of restoration. So I refuse to compete in the commodity dental market. A filling is not a filling, a crown is not just a crown. And ultimately, we and the patient get what we pay for. And I want to just make sure that when we seat our restorations, that we can take pride in what we deliver. Now, in aesthetics, it's funny because I meet with a lot of doctors. I'm usually out lecturing 4 to 6 times a month. So I meet with doctors all over the country and I have a chance to talk to them. And a lot of doctors will say, well, I'm not really focused on aesthetics right now. And I'll ask them, well, why not? Because I think aesthetics right now, I've seen an uptick. I'm in Sacramento, California. And we've seen an uptick in the request for veneers, like I haven't seen in the last 15 years. And I think a lot of that is because of selfies and Zoom. We take a lot more photos today with our cameras. We're on Zoom calls and we might be in front of a screen seeing ourselves like I am today for an hour. And I see my teeth are dark, or maybe they're a little crooked, or maybe they're worn. And so our patients realize what their smiles look like and they come to us for some solutions. And the number of Zoom calls has zoomed up since COVID. And really, we think the Zoom boom is really pushing the cosmetic dental market ahead. And when you look at the research out there, it shows that people that have nicer smiles are believed to be smarter, friendlier, and nicer people and have more friends. And so there's always this positive connotation when we can smile and we have a nice smile to show. In our practice, our vision is just to bring smiles and health to everyone. Now, to kind of put that in perspective, I'm just a family dental practice. We don't market ourselves as a high-end aesthetic practice, but we're just a good family practice. Take care of people or patients from 2 years old to 102 years old and have fun doing that. All right, let's step back. What we're going to talk about during this program is communication. How do we understand what it is that the patient wants, and how do we develop the trust so the patients want to say, let's do what you recommend? We're going to talk about a menu of services we can offer. I call them the platinum menu of services. They're services that our patients desire. They actually want us to provide them. So we're going to talk about that. Then we're going to talk about function. Because if I change the occlusion, if I deliver the veneers and maybe make teeth a little bit longer, I need to make sure that those teeth function so that they aren't destroyed by the occlusion. And then we're going to talk about how to put all the pieces together. I'll show you a case at the very end of the patient where we've got a deep overbite, we had TMD issues, and we had aesthetic issues, and how we brought that all together at the very end. And then what I want to do is I want to wrap it all together to help you understand, okay, how can you do more of this type of dentistry? And again, I call it everyday dentistry. As you tell your patients you're doing more of this type of dentistry, you will have more coming in and requesting it. So I've been in practice now for 37 years. I do practice in Sacramento, California. I have been involved with the Pacific Aesthetic Continuum and other groups for about 34 years teaching. I do a lot of live patient treatment programs. We have one slated for the end of this year, October and November, where we're going to take doctors and we're going to have them prep with us, and we're going to have them seat the cases with us. And the core dental lab associated with the Pacific Aesthetic Continuum is going to be doing the work. We do a lot of live patient treatment programs over the shoulder, even in our practice, where doctors have a chance to get up close and look right over our shoulders to see the little things, like where is our finger rest as we are prepping out for veneers. And we have things on video cameras so the patients, the doctors that can't look right over the shoulder can actually see up close what we're doing. So what I present today is just kind of the experience that I've had for the last 34 years, answering questions that doctors have, and then I've implemented a lot of these ideas into my practice. So this is our group, our class of 2024, working with the Pacific Aesthetic Continuum. These are the doctors that will be preparing their patients with us in a live situation and then seating the case with us also. So I'm going to just talk about a checklist. When I do an aesthetic case, I want to have a checklist. If I go fly a plane, I have my checklist. And before I start the plane up, I have all the steps I need to go through before we start the plane up. And one of the things that I like with the checklist that I get from the lab that I use here is it starts out and it's very systemized. The first thing is they ask, what kind of materials do you want to use? Is it going to be gold, zirconia, porcelain, Emax, or anything in between? Another critical part when you do aesthetics is understanding the shade. So if I'm going to use a thin porcelain, if the underlying shade of the preparation, let's say it's an endodontally treated tooth, is a black tooth, we're going to have to figure out how to block that out. So I need to explain to the lab that maybe I have a black tooth and I want it to look bleached white. Well, I can alter the way I prepare that tooth, maybe prepping a little bit deeper so the material will be deeper or thicker, but they can use a more opaque material to block out that dark color. So we need to share that with our lab. I need to tell them, okay, I have this short centrals that we saw in this case, and I'm going to make them a little bit longer. Well, how much longer do you want them to make those centrals? Smile design. If we're going to do a veneer case, there's different types of smile designs we can create depending on the catalog. So they have an area there where we can specify. And then this part I like. It's what are the goals of the patient? Are we trying to feminize the smile? Are we trying to make it look more youthful? Because that affects the contour that the lab will use when they do their diagnostic wax up. So it's really important for us to understand the patient's goals. A lot of times what happens is a patient will come in and a doctor will say, I know what kind of smile you need. And you deliver the smile you think that patient would want with the proper proportions, the width to length ratio, the going proportions across the front, only to find out that your patient has a whole totally different vision. So what we have to do is we have to work with the patient to really see what their vision is and then kind of communicate that to the lab. Oftentimes the lab never has an opportunity to meet the patient themselves. Things like incisal translucency, as we talked about in that last case. Do we want to have any translucency, or do we want to just have a more bright veneer? If we're doing a bridge, what type of ponic design do we want to have? Surface texture. Do I want it to be smooth like a chiclet, or do I want to have some surface texture to break up the light? Here, do we want a really shiny surface or maybe a matte surface? So again, you could specify that. And I think this checklist is really important. What am I saying to a lab? Are they going to get a stick bite if I'm doing an aesthetic case and the occlusal plane is canted? Are we going to level that out? I have to share with them some information. The bite registration, are we going to be opening the bite? Are we going to be altering the bite at all? Are we going to send them a face bow? So these are just some little boxes that I can just look through. And it's just a reminder, oh, I didn't send the face bow and I did want to. So let me just take a face bow really quick and check it off and that we're putting that in with the case. With the shade guide, a lot of times what we do is we just write down, I want an A1 veneer or an A2 veneer, whatever, or crown, whatever it may be. But what this box shows is that we can have a brighter, higher value in the very center. So maybe the center is going to be a B1 or a bleach shade. And as we work our way up to the gingiva, where we have that warmer shade up there, maybe we want to work it down to an A1 shade. So what we can do is we can actually write down in this box how we want to blend the colors together. And maybe you want your cuspid to have a little bit more warmth than your central and your lateral. And then right in here, additional instructions. I usually write down, because I'll take photos, that I'm going to send them the photos of the case. I'm going to email it over to lab. And then the last thing I write in there is thank you very much, because the technicians and I are working on this case as a team. So I'm very appreciative of the attention they're going to give this case. Now, why do I feel it's important for us to look at aesthetics too? Is because it's being predicted that we could go into a recession, or that those of us that take insurance, maybe our revenues will go down. And we all know that having a dental practice these days requires a lot more revenue because of wage inflation and the rising costs of our materials. So especially what I tell young doctors these days, because they all come in and they're just trying to figure out, okay, how much am I making per hour? And I tell them, I go, don't worry about what you're making per hour. Think about what you're making with each case that you do. So if you do one crown, let's say you make $1,000. If you do 10 veneers, you might be making $10,000. And so for the same input of time, the fulcrum being you're doing aesthetic cases, now your output or the revenue you generate goes up. And guess what? Patients love what it is that you're giving them. So again, they're seeing the selfies, they're doing Zoom. We need to improve their smiles, because the statistics say in the American Academy of Cosmetic Dentistry, they've been saying for decades that only about half of Americans like their smiles, which means the other half don't like their smiles. And that's the potential for us in our practice. So think about what your fulcrum is. Is it going to be aesthetics, cosmetics, maybe it's implants, but try to figure out how many fulcrums you can have. So let's jump in. Let's talk about communication. So I was talking about comprehensive aesthetic dentistry, and that's because I believe it has to start with a comprehensive examination. One, so we really know what's going on. So we look at the occlusion, but two, when we're thorough about things, the patient perceives us differently. If I jump in there at the end of a hygiene visit, a new patient hygiene visit, and I say, "Oh yeah, you got these dark teeth. We should do veneers for you," that doesn't really instill a lot of confidence where they want to say, let's do it. But if I spend an hour and I go through and I look at the worn teeth and we talk about the color of the teeth, and when I'm done, if they trust us and they like us, they're more open to listen to the ideas that we have. So we have to figure out where we're starting and where the patient wants to end up. And I think comprehensive means treating the person as a whole person more than just the teeth. We have to understand their wants, their concerns. We do have to look at all the restorative, perio, endo, infections and things that are going on. We have to look at the joints. We should look at their occlusion, do an oral cancer screening, especially in this month of April. We have to look at the medical condition that they present with. And then today, I know a lot of us are looking at airway that affects posture, which then affects jaw position. But I think one of the things that we can't forget is to ask them about their aesthetic concerns. It's not an infection, it's not a periodontal condition, but it is something that if we don't take care of, we're going to fail them. So if a patient comes in and we see that they have aesthetic needs and we just jump right into that without addressing the periodontal needs, it's a failure. If we just focus on the periodontal needs, but we never get to their aesthetic wants, then to our patients, we could be failing them. So what we have to do is we have to get to know what the patient's concerns are. So what I do is I have two intake forms. One is one that asks, medical history, dental history, and then the form on the left-hand side asks them things like, do you like the appearance of your teeth? Are there crooked teeth? Are there dark restorations that you don't like looking at? And on the right-hand side, I have another form that asks them about function. Do you have areas where you have pain, like maybe in the jaw joints, in the temple area? Do you get headaches? Do you have clicking and popping of the jaw joints? Do you have vertigo? And when they fill out these paper forms, all I do is say, well, it's very nice to meet you. I'm glad that you're here. So I see on these forms that you've checked off that you get headaches or you don't like the appearance of your smile. So tell me more about that. And they'll tell you, well, my teeth are worn or they're crooked or they're dark or I wish they were whiter. So I go back in and just say, okay, so what I hear you saying is that you would like to do whatever XYZ. So then I kind of step back because it's the first time I've had a chance to meet the patient. Haven't done a clinical exam, but I've just had a chance to figure out where they're at, what they want to focus on. And I'll ask them, okay, now we're going to do the clinical exam. And that's so we can set up a baseline of where we are. As we're going through, I'm going to explain to you what it is that we're looking at as we do our exam. But if you have any questions, then please feel free to ask. And if it's okay with you, what I'll do when we're done with this examination is I'll give you some ideas of what we can do to accomplish what your concerns and areas of focus are. And then what I need to do to take care of some of the clinical things that I see, because they may be focused on aesthetics and may be focused on their periodontal disease and maybe TMJ. And just ask the patient for a permission statement. Are you okay with that? And do you understand? And a lot of times, right there, the patients will just relax because they know you're not going to try to sell them anything. They know you're going to be thorough. And as you go through and you do your examination, you're looking at the perio, the restorative, you're looking at the soft tissue, the teeth, the occlusion, the jaw joints, and you're really looking at everything that's going on. And when you get done with that exam, they're more receptive. And this was just an testimonial that was posted on our website, I think 2 weeks ago. So I put it in here, and the patient just said, "Hey, they gave me an outstanding examination." So that was nice to hear. So here's a point that a comprehensive examination should include looking at the patient's clinical situation, their medical and dental history, and then also taking the shades of the patient's teeth and asking if they like their smile. It could be you ask them directly or maybe with that form. Because I know it's hard to meet a patient for the very first time and say, man, you've got ugly teeth. We need to do something about that. But if they have it on that form where they don't like their smile, it's a lot easier to approach. Okay, so now the patient's interested. They go, you know what? I do have some occlusal concerns. Now we launch into our menu. And one of the things that I've learned as a dentist for all these decades is I want to try not to create problems for the patient. So and if I can do that and I can do it in a way that where I have less headaches, then it's better for both of us. So I try not to make a habit of doing harm, as Hippocrates stated. And now there's this movement, minimally invasive dentistry, where we try to restore form, function, and aesthetics in as minimally invasive a way that we can do. So I'm going to show you some of the things that I do in our practice. So there's whitening, there could be recontouring, where you just take the patient's teeth and recontour them without restoring them. I'm going to show you how we move teeth. how we look at occlusion. And sometimes when we're working with occlusion, we can very conservatively restore a patient's bite. We're going to talk about minimally invasive implants, veneers that are minimally invasive, and how we tie it all together in our practice. So in 2004, one of the areas where I see potential is what we call the ABC approach. Let's see if we can align the teeth. Maybe we bleach the teeth, or maybe we do improve the contours of the teeth. So when it comes to alignment, I know a lot of us use clear trays, Invisalign, and the sort. But again, the value of straight teeth is that it can enhance our careers and our relationships. So let's value taking care of this for our patients. So this patient, let's say they present to you and they go, you know what? I want wider, straighter teeth. And I had a patient that presented just like this about a year ago. And I didn't put the pictures in with this case, but she presented like this. And I looked at that and I go, what do you want? She goes, I want veneers. And I said, well, you know what? If we have veneers, we're really going to have to take a lot of tooth structure away because your front two teeth, one, are overlapping and such are the other ones. So if I'm going to do veneer preps, we have to open up spaces between those teeth and we're going to have to do a lot of tooth reduction. So then I would look at first asking the patient if they would do something so we could move the teeth, either clear trays or what I prefer to do in my practice is use brackets and wires. And so I use a system that I learned a decade ago called CFAS. It was cosmetically focused adult straight teeth. And what I'm trying to do is I'm trying to move the teeth so I don't have to remove tooth structure or prepare the teeth. And so if a patient has crooked teeth, one of the first things I think about, I'd love to do veneers for you, but I'd love to do it in a minimally invasive way. So if they're really a candidate for tooth movement, if their periodontal health and their joint health is looking good, and if I think I can move those teeth within 6 months with what I'm going to show you in just a second, then I'll go ahead and keep them in the practice. And what we're going to do is we're going to cosmetically move their teeth. So I may not move the back teeth. I may just align the front teeth, the ones where we may intend to place veneers, so that I can do minimal tooth reduction if we have to do any at all. So we're going to combine anterior aesthetics with our conservative tooth movement. So what I do is all I do is I take some photos, I take some models or scan, and I send those to a lab. And what the lab will do is they'll set up brackets. And these brackets are clear brackets, and we use nickel titanium low force wires that are coated white. So I wore these for 6 months. And when I was wearing them, I'd be talking to my patient. It was before COVID. So I didn't always have a mask when I was talking to them. And I'd just be maybe a few feet away from them. And I'd say, you've got some crooked teeth. Do they bother you? And the patient would say, yeah, I wish I could have straighter teeth. And I'd say, well, we have ways of doing it now that won't take, 2 years or 3 years. And they'd ask, well, how do you do that? And I'd say, well, see, I have these on, and there were these brackets and wires, and the patients would be amazed that they couldn't see that I had them on. Well, the way the lab sets these up is they set the brackets up basically parallel or perpendicular to the long axis of the tooth, which is often parallel to the incisal ledge. So you can see that these teeth on the left-hand side, the central, lateral, and the cuspid, now those brackets are angled, but they're parallel to the incisal edge because we don't have a lot of wear and tear here. And what these nickel titanium wires do is they want to go straight. So as they go through these crooked brackets, they have to bend and curve. Well, over time, what happens is that the wire will straighten out. And as they straighten out, they do that by moving the teeth. So it's very low force, very easy to do. So after the teeth are straightened out, as you can see here, those brackets that were off angles, now they're parallel to that incisal edge, perpendicular to the long axis of the tooth. What we really focus on with adult ortho in the aesthetic area is trying to get the soft tissue areas lined up. Because many times in an adult case, their incisal edges are very worn. And when you straighten the teeth up, the incisal edges are all cattywampus. But if the gingival margins are the way you want them to be, where the cuspid and the centrals are about the same height and the laterals are a little bit lower, then if you are going to do veneers or do some type of bonding on those teeth, you're going to be able to have an aesthetic case. So now we just have a better place to start than what we were before. So this is the lab slip that I use. And what we do is we use round aesthetic nickel titanium wires. We use clear brackets. And the lab can set it up where we only move the front teeth. We're not going to alter the posterior occlusion. And we just go through, I use a 0.14 wire, a 0.016, a 0.018. And every month we go from the smaller wire, the 1/4, the 1/6, and the 1/8 typically. And because it's a round wire, it doesn't engage the brackets, so we don't have to worry about torquing the teeth out. We're just straightening them out. And just from an aesthetic point of view, it makes my treatment much, much easier. All right, so that's the A. Now we're going to get into the B. And really quickly, the way that the B works is as we're doing our comprehensive examination, we've told the patient, hey, you've got 3 to 6 millimeter pockets. That just means we're losing a little bit of bone. Then you pull out your shade guide and say, well, you know what? And the shade of your teeth is an A3.5. And then the patient's going to ask, well, what's A3.5 mean? Well, here we have a little shade guide, and the A3.5 is way down over here. Wow, that's really dark. But yeah, see if I put that shade tab up to your teeth and you can hold the mirror. Do you think that matches the color of your teeth? Yeah, it does. Well, how do I get over to the other side? Oh, what's that one? B1. Well, funny you should ask. We can do that for you. And what I've just started incorporating into our office this last month is we have 3 different methods I've told the patients. We have the in office with the pretty strong stuff. We have to cover up your gums to make sure that we don't irritate your gums. We have the custom made trays that you put a gel in and you wear them at home for about half hour a day. And then we have the strips. Well, now, because I had a lot of patients, they get the trays, but they're too busy. They come back 6 months later and say, hey, how's the color of your teeth? Oh, yeah, you know what? You made me those trays and I never did it. Or they use the strips. They bought the pack of strips. They never did those either. So what we're doing now is when the patients are in the chair for their hygiene visit, what better time than then to do the whitening? Because now they've got their teeth cleaned, and we did a couple of these today where I just told the patient, "Hey, would you like to lighten your teeth up because you just got them cleaned?" And the patient's like, "Yeah, that makes sense." And so we use this. We use this little light you see in this example. This is a patient we saw this morning, and the light actually activates the hydrogen peroxide, creating nanobubbles to increase the effectiveness of our whitening. And this is a lower concentration of hydrogen peroxide, so we don't have to cover up the gums. At the end of my hygiene visit, Bobby here, my hygienist, just asks the patient, hey, do you want to do this? He paints this on, brings the light up for 10 minutes, pulls it away, wipes it off. And we're getting a color change that the patients are really happy about. And I've told the patients, I go, when you come back in 6 months, we'll do it again. So we've combined our hygiene visit into the whitening. All right. So C is contour. So what I'm going to talk to you about contour is how can we be really conservative. And what I'm going to talk to you about right now is really no prep type of veneers. So no prep is great. We don't have to take any tooth structure away. If a veneer were to pop off, they're going to be back to the original tooth structure. So I tell them, it may not look the best, but you're not going to have to worry about sensitivity. What limits us doing minimally invasive procedures? Well, if we've got teeth that are flared out or teeth that are overlapping or way out of the arch form, that makes it much harder. So how do we get around that? Well, we do the alignment. So we use Invisalign or a clear tray system or brackets and wires like I prefer. Well, I can't make really thin porcelain veneers because I've got this dark tooth. How do we get around that? Well, you do the whitening. So you whiten those teeth up. And we don't have a chance with the time to get into it today, but sometimes if it's an endodontically treated tooth, I'll do internal bleaching to lighten that tooth up, and you can get great results doing that. And now we can do these very conservative, no prep veneers. So no shots, no drilling, maybe a little enamelplasty here and there. But what we do is we just take an impression, send that to lab, and ask the lab to make us no prep veneers. And when we look at these and the health that you see there on the left-hand side, she's had these veneers on for 5 years. And you look at that healthy tissue because we didn't have to take away any tooth structure. And she's been very, very happy with them. So if the teeth are crooked, we straighten them out. If the teeth are dark, we lighten them up. And then we can do very conservative, no prep veneers. Now, I forgot, in this case, I had this question, why not do ortho? Well, because sometimes when patients have these spaces between the teeth, they'll come in your office and they'll ask you to bring the teeth together to close up those spaces. Well, in these cases, we don't want to bring the teeth together because that will interfere with function. So if I've got teeth that have spaces and now I bring them together, what that's going to do is it's going to contract, let's say, the maxillary arch, the arch form, and now the mandible has to fit behind those teeth, and that's going to cause the mandible to drive the condyles back, and we don't want that. So again, what we're going to look at when we do our comprehensive exam is, are there fractions? Are there worn incisal ledges? How extensive is the wear? Is it light, medium, or heavy? And when we look at this before we do our aesthetic restorations, we're going to advise the patient, well, look at your natural dentition. If I place veneers on these teeth, what you're going to have to be concerned about is the wear and tear. So whatever you did to wear your natural teeth down like this could break a veneer or cause it to pop off. So one of the things that we should do is we should look at what's going on with your bite and address those needs. So what we're doing is we're looking at the patient as a whole, not just teeth and gums, but we're looking at the patient. We're looking at how the condyles work. We're looking how the muscles are working. Do they get headaches? Do they have uh, pressure or tension in the neck area? And we're looking at how the central nervous system works. And I mentioned earlier, we're looking at posture and airway. So this is kind of my decision tree that the patient comes in for the initial contact, we do a comprehensive exam. If when we're looking at the occlusion or the function, everything looks good, hey, we can go and do those veneers. But if there's signs of occlusal instability, a lot of wear and tear or loose teeth, then we got to ask the patient, would you mind if we first took care of those issues and created good stability in your bite? Once we have the stability in your bite, then we can move on to phase two, which could be the veneers. And then when it comes to doing implants, because we have so many patients that are missing teeth, and that's a cause for them to not have the smile they desire. What I'm using today is a one-piece implant. And what we do is it's a minimum invasive implant system where we do kind of a tissue punch and osteotomy. When the implant goes in, it's a single piece implant where the fixture with the threads and the bone and the abutment that goes through the soft tissue is all one piece. And then on top of that is the restorative platform. So this case is one that we did. She had some PFMs that were across the front. She had a bridge in the front anterior right area and a bridge in the posterior left area. And she did not want to have bridges replaced as we were redoing her aesthetics. So with this minimum invasive implant system, without having to create horizontal and vertical incisions, what we're able to do is take off all the old crowns, finesse the preps, place the two implants in the 7, the 1-2 area, and the 13 or the 2-5 area, and then put the impression copings on there. And in that during that same appointment, take impressions for all the final restorations. So again, the reason why we're here during this program is that we're talking about aesthetics, mal design, we're talking about occlusion, and now we're throwing in implants. So how do you put all the pieces together? Well, you get a patient that says, hey, I want you to close up these spaces between these teeth. Can you do it orthodontically? I would tell that patient, I do not want to do this orthodontically because it will constrict the maxillary arch, which can cause TMD issues or more wear and tear of the teeth. So what do? Is we take a good impression. We send that impression to a lab like the one that we use at the Pacific Aesthetic Continuum, and they give us back a gorgeous diagnostic wax up. Really, really nice incisal embrasures and facial embrasures, nice tooth form, and they make a putty stent over that. And they send me back three types of stents. One is so I can make a temporary, or I can do an overlay, acrylic overlay over the patient's teeth before we prep them. One is so we can see the needed facial reduction, and one is so we can see the needed incisal reduction. So here's a preparation guide just showing for that diagnostic wax up. I put this on the unprepared teeth, and I could see how much porcelain they could add to the facials of these teeth. I do not have to do any tooth preparation, which is nice. I put in the incisal preparation stent, and I can see how we can lengthen these teeth to get the proper width to length ratio. I don't have to do any incisal reduction on these teeth. So what I do is I take the diagnostic wax up stent and I dry the teeth and I fill the stent up with a self-curing temporary material. And I place that stent over the patient's unprepared teeth, just kind of press it up against the gum line. It kind of tissue trims that area. I wait for 2 minutes. And at the end of 2 minutes, you peel that place stent towards the buccal facial to release it, and then peel it down at an angle off of the back second molar, first molar, second bi, first bi, cuspid, but bring it off at an angle so you don't just pull that overlay off will allow you to leave that acrylic over the teeth. Now I grab a cord packer and I run it from that material up towards the gum and just kind of shear off the flash. Now with this acrylic overlay, the patient's able to see it and feel it and function. Just say, hey, say the ABCs, count 1 to 10, and they can feel what that is going to feel like with the spaces closed up and with the teeth that may be a little bit bigger, a little bit thicker, maybe a little bit longer, if that's what you desire. So this gives the patient a chance to tell me, I really like this. And what a lot of them will say is, I can't wait to come back. Or, if we don't take our final impressions today, because a lot of times we're doing this before we even make the financial arrangements, because I just want the patient to understand and value what it is that we're talking about. Because now this case is worth $10,000, whereas before maybe wasn't, at least in the patient's mind. What we also do is we take the shade tab photos because this overlay is probably an A1. It's very dark, but the patient want to go with the lighter shade, a BL1 or BL2. What I always try to do is I try to take this overlay off one side at a time. So here I've taken the stent off his right side so he can see the difference, the difference in length, the difference in size, a little bit different in color. And then I can see how thick the overlay was. Do I want to prep a little bit or do I not need to prep at all? And then if I was going to do a very conservative prep, what I would do in some patients' cases, I would lay the acrylic stent over the teeth and actually prep into the stent, doing depth cuts and such, so that it minimizes the amount of enamel reduction that I have to do. Well, then the case comes back and it's just bonding to enamel. It's really, really easy. So these are all the steps that I do a lot of times if I'm bonding to dentin. I put a rubber dam on. I have to make sure everything stays hydrated but clean. But if I'm bonding to enamel, I get rid of a lot of those steps, the ones that are in the red. So the bonding is much, much easier. So here we go. We didn't have any temporaries to take off. The patient's not even numbed up. We've gone and etched the teeth. We placed our primer adhesive on the preparations, and now we're just taking our lutein resin and placing them over the unprepared teeth. Very, very easy. And then we had a happy patient at the very end. He had no tooth structure removed and had the smile that he always wanted and didn't have to go through 2 years of ortho. Well, I want to show another case. This is one I was mentioning earlier where we have some functional issues. We have the very deep overbite. If you look at the teeth, the two centrals, they're at different heights. Gingivally, the one on the right central is lower than the left central. So what did we do? Is we did ortho. We raised up the right central. We intruded it a little bit so that the gingival zenus would be at the same level, and then went ahead and prepared everything. Now, this case, what we're doing is we're also taking care of some functional issues. So what I do is I don't just palpate the patient's muscles, but I actually put, we call it duotrodes, little pads on like you would use to measure a patient's EKG. And we put them on the muscles to see what the muscles are going to do. So on this left-hand side where you see a lot of color there, that's where we have a lot of muscle activity. It's actually hyperactive muscles, which aren't good. This is what the patient did when they were closing in their habitual CO with that deep overbite, because the mandible was having to tuck, well, the muscles were having to tuck the mandible behind the maxillary teeth. Well, now once we restored this patient, you can see the EMGs went down. Either at rest or light CO in the final restorations, there's very little muscle activity because there's no accommodation the muscles have to do to reposition the mandible. So what we do is we look at how the jaw is tracking, and what we want, and this is again, just a concept I want to take away, not maybe understanding the whole thing, but there's a trajectory. There's a trajectory where there's a physiologic trajectory where the mandible's unimpeded. And then there's a trajectory that's more habitual. That's just where the mandible has to travel to get the jaws to come together, the teeth to come together. Well, the habitual could be pathologic, causing headaches or breaking teeth. If I can get the habitual trajectory and the physiologic trajectory to be one and the same, that is our goal. So on the left-hand side, you can see the deep overbite. And on the right-hand side, we restored the uppers. And on the lowers, we actually have the patient in what we call fixed orthotic. But you can see that we got rid of that deep overbite. So now the mandible is able to come forward. And that's why now the habitual and the physiologic trajectory are one and the same. And it'd be nice to spend more time to go over some of these concepts with you in the future. So my restorative occlusal therapy is to level out the maxillocclusal plane, establish a good position of the lower jaw, the mandible, where the muscles are comfortable. And then we go ahead and plan to that treatment position so that once we restore the bite, or if we're going to do orthodontics to move the teeth, that the bite feels very comfortable and we have very little occlusal adjustments to have to make, because the proper occlusion is critical to the long-term survival of our aesthetic restorations and to the comfort of our patients. So as we come to the end, one of the things to remember is that one is too small a number to achieve success. Take some of these ideas, and I hope you're able to implement some of these ideas tomorrow in your practice, or at least your eyes will see the possibilities. You have to train your team. If you do a lot of aesthetics, or at least in your mind you do a lot of aesthetics, but you're not doing a lot with your hands, go back tomorrow and remind your team that, hey, we have to look at their patients. We have to look at the aesthetic possibilities, and then let your patients know that you do aesthetic work. Use social media to show your aesthetic work and put pictures up in the office. And then remember, use that acrylic overlay that allows patients to understand what it is you're talking about so they value your work. And then on social media, you have to let people know that you do this type of work, and you have to know how to do it. It's funny. I get patients that come in and they go, "Hey, can you do my veneers?" And I go, "Yeah, but where are you coming from?" "Oh, I'm coming from Dr. So-and-so's office." "Well, why don't you have Dr. So-and-so do the work for you?" And you know what? The patients will go, "Well, I don't think they do aesthetic or cosmetic work." And we know that you do. Well, what happened was that dentist that they were seeing either didn't ask the patient if they had any aesthetic wants, and they didn't let the patient know that they could take care of those aesthetic wants. And so the patient went somewhere else. And I don't want that to happen to those of you that are on the program with us today. So what we've covered is communication. Do your comprehensive exam. Understand what it is that your patients want so you know what it is that you need to deliver. Have that menu of the platinum services, the services that the patients want, so you can do very minimally invasive procedures. Remember that function matters. So I know when I got a dental school, occlusion function was one of the things I knew nothing about. So try to find a program and study it a little bit, because I think it's critical to what we do. And then think about how you are going to put all this information together, everything that we covered in this hour, remembering that you can't do everything on your own, that you have to have a good lab, you have to have a good team behind you. And then we're able to do this minimally invasive dentistry that I think is better for our patients. So I know we went through a lot of things. So this is just a resource list. You can just grab a snapshot of this. Some of the organizations that I work with, that Blanc One USA, that's that whitening system that I use. It's just starting to come to the United States. It's actually originated in Italy, and they're just bringing it to US if you want to be one of the first ones to use the system. But right now, we've got our Q&A time, so I hope there's some questions that people have. I'm going to open up the Q&A and the chat. Let me just take a look and see what we have. Let me hit Q&A first. Okay, so the question was, what lab did you use for that case? All the cases that I showed this evening were done by the Pacific Aesthetic Continuums Lab, core dental lab here in California. So we'll give you more information on that in just a bit. And then let me open up the chat. With your new whitening system, has anyone had reactions to the gingiva, and do you still need to keep someone in the room with them the entire time? Could an assistant do that? And lastly, what was the name of it? So again, the name was Blanc One, BLANCONE. We have not had any reactions to it. I asked my hygienist that today, because we have our hygienist doing this. Your assistant could do it for you. But again, we have it on our hygiene chair. So the hygienist can say, "Hey, I'm done with your cleaning. We've got 10 minutes. Would you be interested in us doing the whitening?" So your assistant could do that. And I asked my hygienist today, I said, "Hey, you've been doing a bunch of these. You've been getting some on the gum, right?" And he goes, "Yeah." I said, "Have you had any reactions to it?" We have not. So that is something that we feel really good about right now. Where did you learn the occlusal changes on the last patient? So the occlusal changes, it's the philosophy that I've been using for the last 20 plus years. I just taught a course on it. It was a 2-day course in Chicago a week and a half ago. So it's from Myotronics. So my background really quick is in CO dentistry, is what I did for many years. And then when I figured out maybe CO wasn't the best way to do large cases, I learned how to do CR. And then today I use all those, and I use the bioelectric diagnostics with some associated with neuromuscular dentistry. But And saying that, you will not leave one school of thought. You're going to tie them all together. So there's going to be things that you understand with habitual bites, manipulated bite, maybe a deprogrammer bite, and that you use the bioelectric equipment with. Why I like the bioelectric equipment is when I'm teaching occlusal philosophies, I'm able to show the doctors how the patient's responding when we make these bite changes. One of the things that helps me when I'm dealing with the patient, like the acrylic overlay, is I can show the patients, hey, here's your muscles in your habitual bite. And I show them how the muscles are hyperactive. And that's where you get headaches here. And that's where you get headaches here. And now I reposition their jaw whichever way is best for them. And now look at your EMGs come down. And how do you feel with that bite right now? Oh, that feels really good. Well, I can show you that your muscle activity has dropped down. That's a more comfortable bite. And if we keep you in that bite, those headaches are going to go away. Sometimes the vertigo will go away. I've even had patients say that their vision got better. Now, I don't promise that to the patients, but if you think about the TMJ, when you have tight muscles here, it's right by the cochlear apparatus, the hearing apparatus, where you have brain in the ears. It's right by the vestibular apparatus, which causes you to have vertigo. And it's right by the eyes. They have all the small muscles. And if we can relax the muscles, then we can get some great results. Now, how much do you charge for that office whitening during hygiene? Well, the way that I'm thinking I'm going to do this is I'm going to charge about $100. Why $100? Because for my custom made trays, right now, I think in our office, we're charging almost $300. And for the in office, I think we're charging like $700. So at $100, it is the least expensive of the whitening. Even our trays, I think, are maybe a little bit over $100. So it's going to be the least costly of the whitening options we have to offer in our office. It's going to be the easiest option for us to offer in our office. It's going to be the one the patient has delivered while they're in the chair. So I'm going to be sure that they are going to do it right. And then like the patient we had today, I told him, my vision is, I told him this was something we had just implemented. It's from Italy. And it's going to be 10 minutes. We're going to whiten your teeth. And he saw the whitening. And I said, when you come back in 6 months, we can do this again. He said, you know what? I'll do it again. He said, I'll pay for it. So again, the patients see the value in this. And that's why I'm excited, because I hate making custom made trays and having them sit in my chair for an hour and a half for the real strong stuff where we have to block out all the tissue. So this right now to me is a way that we can generate more revenue in hygiene, because our hygienists deserve it, but their wages have gone up just like everybody else's wages. And unfortunately, a lot of you that take insurance haven't seen your reimbursement for pro fees go up. And this is just another adjunctive service that the patients want, again, that we can offer during their hygiene visits. So I think with that, and I've got about 7 more minutes. Oh, one more question. What about the new ceramic printed crowns? Good, great question. I will tell you, I have not tried a printed crown. I will tell you the reason why is I'm waiting for the materials to prove themselves out. I've talked to some doctors that have tried the printed crowns, and they just didn't seem to be as strong as the ones that are milled or fabricated with other techniques. I've talked to some doctors that will tell me that even their night guards, that when they print a night guard or when they have a night guard fabricated, that the printed night guards haven't held up as well. And again, this is just hearsay. It's just me talking to my colleagues. And because of that, I'm waiting for time to kind of vet out how these printed crowns are going to function, because, we've all used new materials that didn't pan out well in the long run. And I don't want to place 100 printed crowns, because they are, and I think they're going to be the technique of the future. But as we've seen, as new materials come out, a lot of times the strength isn't really there. And I don't want to do 100 of these crowns and find out that I have to replace half of them 3 to 5 years down the road. So I'm going to let somebody else do that testing for me. So I think we have to keep our eyes on it. But yeah, I haven't started to do those yet myself. Here's one more question. What bonding system do you use? I'm thinking in bonding system, is that um, like Luton cement. I use Ivoclar's Luton cement, veneer Luton cement, the light cured. And how long does the whitening the Blanc one procedure take? It takes 10 minutes. And so, 10 minutes with the light, about 50 minutes for the whole thing, because they've already had a cleaning. You just dry the teeth off, you paint on the gel, you bring the light up, the light's there for 10 minutes. And when that clicks off, you just wipe off the gel and hand the patient the mirror so they can see results, and that's it. So the entire process probably adds about another 12 to 15 minutes. My hygienist, we give all our hygienists an hour to do a prophy. And usually it's those cases, they get done usually in about 45 minutes. And so we can just tack this on at the very end, another 10, 15 minutes, or they're doing oral hygiene instruction with our patients. So, but the patients love to do the whitening. So we're having good success with it right now. Great question. And thank you very much to everybody for attending.